as we are at the intersection of technical execution and clinical care. And in situations where we are uncertain about the best approach, whether it's the best sequences to run or the ideal positioning for a specific case, then don't hesitate to consult your radiologist. These conversations deepen our understanding and enhance patient care. It's in those very moments of collaboration, curiosity, and even shared learning that we truly evolve in our practice. And with that said, I will just now dive right in. So MRI is widely regarded as the gold standard in neuroimaging because of its exceptional soft tissue contrast and its ability to visualize brain pathology in remarkable detail. This makes it the preferred modality for assessing a very wide range of neurological conditions. However, a one-size-fits-all approach is not effective when it comes to MRI protocols. Each neurological condition, whether it's stroke, multiple sclerosis, epilepsy, or even brain tumors, present unique diagnostic challenges that require tailored imaging strategies. Selecting the appropriate protocol based on the clinical context is very crucial for accurate diagnosis and improved patient care. In this presentation, we'll take a closer look at how MRI protocols are adjusted for specific neurological conditions, the importance of selecting the right sequences, and how the radiographer's expertise directly impacts the quality and clarity of the final diagnosis. So let's first look at the key MRI sequences we use in brain imaging, and we'll start with a T1 sequence. So a T1 sequence is great for visualizing the brain structure because it gives us excellent contrast between the gray and the white matter. It's especially helpful when we are looking for things like structural abnormalities, signs of hemorrhage, or even contrast enhancement in tumors. Basically, a T1 weighted image gives us a clear, detailed map of the brain's anatomy, which is essential for spotting anything unusual. A T2 weighted image is ideal for highlighting fluid, which makes it especially useful in detecting edema and a wide range of brain pathologies like tumors, infections, and white matter diseases. Because fluid appears hyper-intense or bright, it also helps us differentiate between solid and cystic lesions, giving us important clues about the nature of what we are seeing. FLAIR is really a powerful sequence. This because it suppresses the bright signal from CSF, which makes brain lesions stand out much more clearly, especially those near the ventricles. It's particularly useful for spotting conditions like multiple sclerosis, stroke-related changes, and infections. And by removing the CSF glow, or what we call brightness, FLAIR help us see the subtle abnormalities that may be missed on other sequences. And then there's diffusion-weighted imaging. Along with the ADC map, it is essential when it comes to detecting areas of restricted diffusion. It's actually considered the gold standard for identifying acute stroke because it often picks up changes within minutes of onset. Beyond stroke, it also helps us differentiate abscesses from tumors and is really useful in assessing ischemic changes or even cellular injury. It gives us quick, critical information, especially in emergency settings, such as those when we're imaging a stroke patient. Susceptibility-weighted imaging is highly sensitive to substances like blood, calcium, or even iron. It's very valuable in neurodegenerative conditions like Parkinsonism and certain forms of dementia, where it helps to detect iron buildup in deep brain structures, particularly in the substantia nigra. MRA and MRV allows us to visualize blood vessels in the brain in great detail, often without the need for contrast agents. MRA is especially useful in assessing arterial conditions like hemorrhagic stroke or aneurysms, while MRV plays a key role in detecting venous issues such as thrombosis. These two techniques are both non-invasive, yet incredibly powerful in guiding diagnosis and treatment plan planning for vascular-related brain conditions. And then we have spectroscopy. So MR spectroscopy goes a step beyond the structural imaging by looking at the brain's chemical makeup. It helps us assess metabolism and can be really useful in differentiating, for instance, a tumor, tumor tissue and radiation necrosis. And it also plays a role in identifying certain metabolic disorders. And while it's not part of every routine scan, when used well, it provides valuable insights that traditional imaging alone might miss. And we'll see these as we progress with the presentation. And then we have functional imaging, functional MRI, or what we call fMRI. fMRI is all about mapping brain activity by tracking changes in blood flow that happens in response to neural activity. Unlike regular MRI, that focuses on the structure, fMRI gives us insights into how different parts of the brain are working and communicating. It's especially useful in pre-surgical planning, and hence helps us to localize essential functions like speech or even movement. It is also used to monitor conditions like stroke, epilepsy, Parkinson's, and Alzheimer's by assessing functional changes over time. And now that we have looked at the key sequences we use for brain, then we'll just go straight and look at a few protocols that we use for MR brain scanning. And we'll start with the stroke protocol. The stroke protocol is all about speed and accuracy. Its main goal is to enable rapid diagnosis so that we can quickly assess the type and extent of the stroke. This is critical for guiding urgent treatment decisions like whether to proceed with thrombolysis or thrombectomy. And the protocol should also help differentiate between ischemic and hemorrhagic strokes, also determine the age of the infarct, whether it's acute, subacute, or chronic, and even identify other possible causes of neurological symptoms. This protocol is also helpful for tracking how stroke evolves over time. So some of the key sequences we use for the stroke protocol, we actually don't do that much because remember we are trying to rush against time. And in the cases of stroke, we say that time is brain, so you have to really be fast. So we do just a few very effective sequences. We do DWI, we do ADC. We also do a flare, SWI, we do MRA, and I will explain why we do all these in the next slide. So we'll start with diffusion and ADC. So in this slide, we have DWI and ADC images from a stroke patient we imaged a few weeks ago. On the DWI, you'll notice a bright area that's showing restricted diffusion, which usually indicates cytotoxic edema caused by an acute ischemic stroke. When we look at the ADC map, the corresponding area appears dark, confirming true diffusion restriction. This combination, that is bright on DWI and dark on ADC, is actually considered a classic signature of an acute infarct. It's a powerful way to detect stroke very early, often within minutes of symptom onset, and it plays a crucial role in timely intervention. I'll go back to the sequences and just explain why we actually need to do the flare before I go to that slide. So the flare here, we say that it helps to detect the stroke age because the event of stroke takes a bit more time to appear on flare as it would appear on ADC. So I'll explain this further with what they call a DWI flare mismatch. So this can actually be a really important finding, especially when we're dealing with acute ischemic stroke. So here is the basic idea. DWI or diffusion-weighted imaging is highly sensitive to early cytotoxic edema. And this happens soon after a stroke event, sometimes within minutes. So it shows up as a bright signal in areas where the brain cells are already in trouble. On the other hand, flare takes longer to become abnormal. So if we see a DWI hyperintensity, but the corresponding area on FLAIR is still normal or only subtly changed, then that's what we call a FLAIR DWI mismatch, and is a strong indicator that the stroke event is still within a few hours of the event. Remember, again, when dealing with stroke, time is brain. And now let's look at another phenomenon they call that the DWI perfusion mismatch. So MRI perfusion helps us to assess how much brain tissue is still at risk but can be saved. We call this the ischemic penumbra. It gives us a picture of blood flow dynamics in the brain using maps like cerebral blood flow, cerebral blood volume, and so on. When we combine it with diffusion-weighted imaging, we get a powerful comparison. Diffusion shows the infarct core, and that is the tissue that is already irreversibly damaged. Perfusion, on the other hand, shows the hypofused area, and that is the tissue that is not getting enough blood, but is still viable, so it can still be redeemed. So the DWI perfusion mismatch tells us how much tissue we could potentially save, and this guides decisions about treatments like thrombolysis or mechanical thrombectomy. And this is especially helpful in wake-up stroke patients or cases where the onset time is unclear, because we then base the treatment on tissue status and not the clock. And then here is an image of an MRI. You can clearly see there is an occlusion or blockage on the right, and there's an abrupt cutoff in the vessel, and the number flow beyond that point is missing or significantly reduced. So basically, that is the stroke protocol. And then next, we will look at the epilepsy protocol. The epilepsy MRI protocol is tailored to help us get the clearest possible picture when evaluating patients with seizures. First, it aims to identify epileptogenic lesions, those subtle abnormalities in the brain that may be responsible for seizure activity. It also helps us to differentiate seizure-related changes, especially when looking at acute versus chronic findings. For patients who are being considered for surgery, this protocol plays a key role in surgical planning, helping localize lesions and preserve vital functions. Additionally, it enhances lesion detection, especially for subtle cortical malformations like focal cortical dysplasia, which might be missed on routine scanning. And finally, it ensures a standardized approach to imaging, so no critical information is overlooked and comparisons can be reliably made over time or even between institutions. So when do we actually use the epilepsy MRI protocol? There are several key clinical scenarios where this targeted imaging is valuable. First, in cases of new onset epilepsy, particularly when the seizures are focal in nature, MRI helps uncover any underlying structural causes. It's also crucial for patients with drug-resistant epilepsy, where we are evaluating them as potential candidates for surgical intervention. One common condition we look for is mesiotemporal sclerosis, which is a frequent cause of temporal lobe epilepsy. We also use this protocol to assess for cortical malformations, and this is things like focal cortical dysplasia or heterotopia that are often subtle but highly epileptogenic. In some cases, we are checking for tumors or even vascular malformation or post-traumatic changes that might be triggering the seizures. And finally, it can also help us evaluate autoimmune or metabolic encephalopathies, which may present with seizures as part of their clinical picture. As radiographers, we do play a key role in recognizing when the epilepsy protocol might be needed, even if the referral doesn't explicitly say so. It's important to actively review the clinical history and read the referral notes. Sometimes the need is hidden in the details, so look out for certain clues. A history of focal seizures is often the biggest hint. Mentions of mesiotemporal sclerosis, temporal lobe epilepsy, or drug-resistant epilepsy, I think those are quite straightforward and strong indicators. Again, pay attention to the more subtle phases in the notes, like cognitive changes, unexplained behavioral episodes, or loss of consciousness. And then also these will also depend on the age of the patient, because something like cognitive changes then in an older patient, then probably that we would opt to do a different protocol as opposed to a seizure protocol. So these could all point to a seizure-related pathology, all those small, subtle phrases. Again, as I said, as I was beginning, it's the power of collaboration. If you're not sure, always consult your radiologist and then agree on the best protocol for the patient. So then finally, if you see a request for hippocampal volumetry or cortical dysplasia assessment, that's a clear sign that a dedicated epilepsy protocol is needed. To get the most out of epilepsy imaging, especially when looking for subtle lesions, we need to be intentional with our technique. Start with thin slices, isotropic 3D sequences like T1, FLAIR, T2, and SUI. These are essential because they allow for high quality reformatting in any plane and help reveal even the most subtle abnormalities. When reconstructing images, especially the axials and coronal views, always align them perpendicular to the hippocampus. This positioning significantly improves our chances of spotting mesiotemporal sclerosis, which is one of the most common causes of focal epilepsy. Again, using a high resolution matrix, for example, 256 by 256 or even higher, will enhance our ability to pick up very small cortical abnormalities or malformations that might otherwise go unnoticed. And finally, minimize patient motion. These might sound very simple, but it's critical. So gentle coaching, creating a comfortable scanning environment, and using motion correction tools if available can make all the difference in getting diagnostic quality images. So for our seizure protocol, these are the sequences we do. So you'll notice that for T1 here, we do not use a T1 FFE or a T1 TFE as opposed to the other sequences. So it's very important for the seizure protocol for you to use a T1 inversion recovery, or at least that's what we use at our facility, because the inversion recovery will give you a very distinct gray-white matter differentiation. So it will help you pick up on very tiny focal or easily missed focal cortical dysplasia or structural abnormalities. We also do now the diffusion, we do 3D FLAIR. So most of these sequences for seizure protocol, we do most of them, actually almost all of them, of course, apart from the diffusion in 3D, so that it's easy to also reconstruct them and ensure that we're not missing any tiny abnormalities. So we also do a 3D T2. We do a susceptibility weighted imaging to detect any microhemorrhages or calcifications, or even cavernous malformations, which can be seizure triggers. In some facilities, or what is recommended is that also spectroscopy can be of use when we're doing the seizure protocol. Currently, we're not doing it at my facility, but I would really love to hear about other people who may be running this sequence, and if it's of significant help to their facility. I would really love to hear that from you guys. So then here we have, this shows just a coronal FLAIR images showing mesiotemporal sclerosis. You can see significant hyperintensities in the left hippocampus. And that is what we call mesiotemporal sclerosis. Again, I wanted to just show a comparison of these two sequences. Both of these two sequences are T1 sequences. The one on the right is a T1 inversion recovery sequence, and the one on the left is a T1 fast field echo sequence. And you can see how worlds apart they are. So with the IR, you can see very distinct gray-white matter differentiation, and that's what we want for a seizure protocol. The FFE is good for other things, but not particularly for the seizure protocol. These images are actually part of a study we did at Sona Imaging Center with my colleague Cliff. I'm sure he might be somewhere in this call. We were trying to compare and see what difference it makes when you do a 2D FLAIR and when you do a 3D FLAIR. So we just picked random patients that we had scanned before, and just try to see, we tried to call some of them back and rescanned them using 3D, because way back, maybe like a few years ago, we rarely used to do 3Ds unless it's unless it was like patients for multiple sclerosis. But then right now we've made this standard for every patient. We do a 3D flare for every patient. And this was as a result of what we noticed that we were like really missing very many subtle lesions in most patients. So we just resorted to do 3D flare for all patients. And that has been a game changer for sure. And that's it with the seizure protocol. I will move on to the neurodegenerative protocol. So this protocol plays a crucial role in the early detection of both structural and functional brain changes, often before symptoms become clinically apparent or very much advanced. It's designed to help differentiate between the various types of neurodegenerative diseases, such as Alzheimer's, Parkinsonism, and frontotemporal dementia, which can often present with overlapping features. We also aim to identify imaging biomarkers that can be used to monitor disease progression or assess response to treatment. And this is particularly important as more targeted therapies become available. Ultimately, the goal is to support clinicians in making informed decisions about the diagnosis, the prognosis, and the patient management, which in turn then contributes to better outcomes and more personalized care for our patients. So when evaluating patients with suspected neurodegenerative conditions, it's important to recognize the specific clinical patterns that may guide our imaging approach. For instance, progressive memory loss or cognitive decline often point towards Alzheimer's disease or other forms of dementia. On the other hand, language difficulties or aphasia may suggest FTD, frontotemporal dementia. Gait instability, frequent falls or tremors can raise concern for Parkinsonism or multiple system atrophy. While behavioral and personality changes are again red flags for FTD, when a patient presents with visual hallucinations and fluctuating cognition, this could indicate Lewy body dementia, which has a distinct pattern both clinically and on imaging. Additionally, involuntary movements like chorea, tics, or rigidity might point out towards Huntington's disease or a typical Parkinsonian wasting syndrome. And finally, weakness, spasticity, and muscle wasting should make us consider ALS, which also benefits from MRI evaluation to rule out mimics and assess involvement. So recognizing these symptoms isn't just helpful for the clinicians. It gives us, as radiographers, the context we need to anticipate the right protocol, know what structures require close attention, and contribute to then meaningful diagnosis. As MRI radiographers, we need to pay attention. Even when the request form isn't specific, sometimes a scan is requested as a brain MRI, but the clinical history might suggest possible neurodegeneration. So in such cases, it's important to double check with the radiologist to see if an advanced neurodegenerative protocol might be more appropriate for the patient. For Parkinsonism disease, ensure you have a SUI to assess ion deposition. It's a small addition actually, but it can make a big diagnostic difference. In dementia cases, if 3D, T1, and FLAIR sequences are missing, then we should advocate for them since they're essential for evaluating brain atrophy and white matter changes. In short, always read between the lines, recognize the red flags, and speak up when unsure. I mean, that's how we learn. You have to ask. If you're not sure, just consult and you'll always get your answer. In turn, you learn more. So that extra attention can significantly impact the diagnostic outcome. So these are the sequences we run for our neurodegenerative protocol. So again, the difference between these and the seizure protocol. For the seizure protocol, we do a 3D T1 inversion recovery. But for the neurodegenerative protocol, then we run a 3D T1 TFE, or that is what the Philips systems call it. In other systems, it will be MPRAGE or FSPGR. So what this does is that it helps to detect any cortical lesions, especially in the detect cortical atrophy, especially in the hippocampus. So for these, you have to use isotropic reformatting, ensure that the voxel size, and that is the tiny 3D pixel in an MRI image, is equal in all dimensions. That's what we mean when we say an isotropic reformatting. All the 3 dimensions have to be equal. So for example, it can be 1 millimeter by 1 millimeter by 1 millimeter, so that you ensure you're not missing anything. Then we do a 3D flare, again, to highlight white matter hyperintensities, which are very common in neurodegeneration, especially early enough. Then we do T2 weighted imaging, of course, to identify the brain structure changes and vascular pathology. We also do diffusion to detect acute ischemic changes or neurodegenerative patterns. A SWE, very important to evaluate ion deposition, especially seen in Parkinsonism and Alzheimer's. And you can also pick out any microbleeds. So these 2 last sequences, we also don't do them at my facility, but I would love to hear your feedback on about them, especially for those of you who are already using these sequences for like the neurodegeneration protocol. I'd love to hear how effective they are, and I mean, it's exciting to see. So for resting state fMRI is indicated that it's optional because, as I said, we also don't do them, mostly because we don't have the licenses. But of course, it's something I would want to experiment more on and see what impact it has. So it's used to assess connectivity and network changes in early neurodegeneration. Then we have MRS to evaluate metabolic changes like reduced NAA, which is an indicator of neuronal loss, or increased myosinitol, which could show then glial proliferation. Okay, so this is just an image to emphasize on the isotropic voxels. So this is what I mean when I say you have to ensure that the reformatting is isotropic. You can see those boxes look different and they all give us different images. On the second image, on the image on the left, you might be missing on a lot of details. So ensure your slices are as thin as possible and isotropic. So this is an image of an SWI image for Parkinsonism. So now in healthy individuals, we typically see what's called the swallowtail sign. This is a normal sign. These are normal imaging appearance of the dorsolateral part of the substantia nigra. Now, when this sign is absent, it can be an early imaging clue for Parkinsonism disease because it shows there is loss of normal architecture in that area, often due to ion deposition and neurodegeneration. So even though SWI is not, even though SWI isn't a diagnostic tool on its own, it adds really valuable context, especially in early disease where clinical symptoms might still be very subtle. So don't skip these in your protocols. This is just an image showing what a T1 3D TFE image would look like, and a 3D reformatted flares would look like. And with that, we are done with the neurodegenerative protocol, and I will move on to the last one, the last protocol that we'll look at today, which is the brain tumor MRI protocol. So when it comes to the tumor protocol, our main goal is to get really detailed images of the brain structure. It is helpful to detect any tumors early and clearly. But we are not just looking to spot a tumor. We want to go deeper. So we use this protocol to help differentiate between different types and grades of tumors and to see how far the tumor has spread or if it's affecting any nearby tissues. We're also checking for things like how much blood is flowing through the tumor, that is its vascularity, whether there is any swelling or edema around it, signs of necrosis or dead tissue, or even bleeding inside or around the tumor. All of this information is crucial, especially before surgery. It helps in planning the approach, tracking how a patient is responding to treatment, and guiding follow-up care. So this protocol is typically used when we suspect a brain tumor. So whether it's a primary tumor or one that has spread from another part of the body, it's also really valuable when we are checking if a tumor has recurred after treatment, or if we are trying to see how well the patient is responding to therapies like surgery or radiation. So before any surgery or radiotherapy procedures, imaging through this protocol helps guide the planning. It gives the surgical team a detailed map of what they're dealing with. Another important indication is when a patient presents with a tumor-associated epilepsy. So seizures that might be caused by a brain lesion. And finally, we use this protocol to help differentiate actual tumors from other conditions that might look similar on imaging, for example, an abscess or demyelinating disease. That distinction is super important for getting the diagnosis and treatment right. So these again are the sequences we use for the tumor protocol. We do use the same T1 3D sequences, so a 3D MPEG or a 3D TFE sequence to provide high resolution anatomical detail, which is essential for detecting mass effects and to check if there is any midline shift or tumor boundaries. We also do a T2 weighted image to evaluate tumor-associated edema, any cystic components, and peritumoral changes. We do a 3D FLAIR pre and post contrast. It's very important in highlighting non-enhancing tumors to check for peritumoral edema and infiltration. So we also do a diffusion, of course, to differentiate tumor from abscess or stroke or necrotic regions based on the diffusion restriction patterns. And again, we also do SWI to detect if there is any microhemorrhages, calcifications, or abnormal vascularities. And this is mostly seen in high-grade tumors. Again, we will also still do a T1 post-contrast, the same one that we ran as pre-contrast. So our radiologist would prefer if you use the same sequence so that it's more uniform and they can actually compare side to side without having to change any parameters. Again, MRI perfusion, we still don't do that, but in some case, in other facilities, again, I'm excited to hear about this from you guys. They do the MRI perfusion, or it's actually recommended to do an MRI perfusion to evaluate tumor vascularity and help differentiate it in differentiating high versus low grade tumors. Again, MRI spectroscopy that we do, MRI spectroscopy will provide metabolic profiling and will help us distinguish between tumors from mimics. For example, you can check the you can look at the ratios, check if there is, for example, increased choline in tumors or reduced NNA in gliomas, things like that. So yeah, that is basically our tumor protocol. However, in some cases, then we will find ourselves adding.
Happiness. Sorry.
Yes. Okay. Right. So in some cases, you might add some additional sequences for some tumors. For instance, if you have high-grade gliomas, for example, a glioblastoma, again, it's advised to always do an MRI perfusion and an MRS to assess the tumor vascularity and see the metabolism of the tumor, hence helping distinguish that tumor from many other tumors. Again, for low-grade gliomas, always do a 3D FLAIR and a diffusion tensor imaging, especially if you have access to these sequences. Always be open to experimenting and really seeing how far you can push the limits. Because I know most of our facilities don't have access to these advanced brain imaging for many reasons. Maybe they're too expensive. Mostly, I think it's a matter of cost. But if you have access to them, then just experiment and, learn. So do a DTI, detect non-enhancing tumor infiltration. Again, we said FLAIR is very good at this to detect non-enhancing tumor infiltration. Also for metastatic tumors, ensure you do a whole brain T1 post-contrast and a SUI to evaluate for multiple lesions, check for hemorrhage and calcifications. For meningiomas, again, a T1 post-contrast is a must, and diffusion to define the dural attachment and to differentiate from other extraaxial lesions. Now, for pituitary tumors, specifically for microadenomas, we run a dynamic contrast enhanced MRI. So we do we also have a pituitary protocol. And part of that, the most defining sequence in that protocol is the dynamic contrast enhanced MRI, which is very good in assessing microadenomas and check for pituitary gland involvement. And then we have for lymphomas, DWI and MRS are almost non-evitable. So so those will be very critical for when you're assessing for a lymphoma. Again, discuss with your radiologists. They are, most of them are, almost if not all of them are always open to giving guidance. This is just an image showing a T1 pre-contrast and a T1 post-contrast, just showing or demonstrating how the role of gadolinium. Now we have a flare and a T2 image here. And again, when comparing these two, on T2, both CSF and edema are bright. You have to always keep that in mind. And these may lead to confusion or masking of edema. However, on flare, CSF is dark. So while edema remains bright, and this enhances visibility of the peritumoral edema, especially near the sulci or around the ventricles. So CSF will basically just be dark, but if there is edema, then it will remain bright. So a clinical tip for this, flare is better, as I said earlier, in delineating and enhancing infiltrative tumor margins and subtle white matter changes. And these can be very easily missed or less well-defined on T2. So therefore, both these sequences are complementary to each other. T2 will give us a broad view of fluid distribution, while flare will enhance detection of subtle edema and infiltrative tumor spread. And lastly, this is just a slide showing an image of a SUI that demonstrates microhemorrhages and calcification on your left. And that is the end of my presentation. I'd love to thank a Smart Africa Network for giving me for this opportunity, and Sona Imaging Center for support. That is my place of work. And thank you to the audience for listening to my presentation. I would really love to hear if there's any questions, and also hear about all your experience in brain imaging.